First, we want to find out who you all are. Which one of these answers best describes you? A, parent or family member of someone with ASD. B, clinician of any stripe. C, researcher. D, consumer. Or E, student. Please fire away. The cool thing about these devices is that you can punch them as many times as you want. If you're not completely sure that it doesn't feel right, just keep punching until you finally reach that state of bliss there. So let's find out who you all are. Okay, very nice. We are officially in the 21st century. So almost 1 out of 5 of you are a parent or family member. About half of you are clinicians. A number of researchers who realize there's a lot more to know about this condition. And only one of you, or 1%, identifies as a consumer, and some other students as well. Good. So that's a great mix, and I think it will be very, very informative when we ask a little bit more about discussion. Now here's a sensitive one. I got some feedback to be very careful about this, but it is helpful to know your general age. I was going to include an AARP member category, but then I thought, no, I don't want to go there. So A, under 18, B, 18 to 30, C, 31 to 45, D, 45 to 64, E, 65 plus. Now, I am remiss in not thanking my my collaborator and conspirator on this talk, Dr. Alice Kuo, who's here. Without her, we wouldn't be functional. But fire away. Okay, we're into triple digits. Great. Survey says. So we have a number in the 18 to 30 group, about a quarter of you. In the 31 to 45 group, 35%. Excellent. And then those in the peak of their vitality, that 45 to 64 group, a good third. Excellent. And then those who are sharing their wisdom with us are represented just under 10%. Good. So again, that will be interesting when we get to some of your observations and comments, because a number of you have been working in this area presumably, or learning about it for some time, and many are newer. So do you know someone personally with an ASD? A is yes, B is no. Wow. So 8 out of 10 of you know someone personally with an ASD. Perhaps not surprising, you're here. You're motivated to learn more, but perhaps also reflecting the fact this is a very common problem, the most common pediatric neurodevelopmental disorder based on current information. Which age group, from your own experience or knowledge, do you believe has the fewest services and supports available in the current system of care? Whatever system you interact the most with or have the most knowledge of. A, infants and toddlers. B, preschoolers. C, school-age children. D, adolescents. Or E, young adults. Okay. So I'm interested in that. Wow. It's kind of a slam dunk consensus. More than 3/4 of you see young adults as having the fewest services and supports available. And then I'm a little bit surprised that you all really see relatively even support for the other age groups. Sir, yes.
Ken Chang, Cerritos. It would be interesting if we could do this survey without E as an option, then you'll have further breakdown.
Yes.
if you'd like.
What do you think, gang? Yeah, that's a great idea. Ignore E, but focus on those age groups with fewest services or supports. A, infants, toddlers. B, preschoolers. C, school age. D, adolescents. Okay, anyone want to hazard a guess of which group is going to pop? I'm sorry? D, adolescents. Yes, wow. Okay. Well, that's almost as, that's all. Okay, you E's, you've made your point. Let go. That's what the mindfulness people say, right? Well, it's interesting. I mean, clearly, whopping consensus, adolescents, but interestingly, I'd like to hear from someone who indicated A, infant toddlers. Just either what that is based on, or thank you. Yes, sir.
Thanks. My name is Dennis Van Vliet. I'm an audiologist and a grandparent of a 7-year-old female on the spectrum. And I think I chose A simply because the diagnostic process takes a while. And so then those infants are undiagnosed and untreated for quite a while. And then prior to 3 years of age, there isn't as much from the public school available. There's some, certainly after 18 months, there's some, but there's quite a chunk there if they, especially electrodiagnostically, they can be identified earlier, there's opportunity for additional services.
Yeah, those are great points. I imagine they are shared or experienced by a number of you. Just the difficulty in getting the comprehensive assessment and evaluation, and then just the frustrating length of time to work through the whole process. And meanwhile, the opportunity for intervention feels like it's slipping away to a degree. In terms of what types of services are most readily available for an individual with an ASD. A, case management. B, early intervention, broadly speaking. C, individual therapy. D, medical or psychiatric care. E, parent or family support. I'm feeling a little tension as the, just with the uncertainty building. Okay. Wow, okay, so early intervention is deemed as most readily available, with the others relatively evenly split, perhaps medical psychiatric care somewhat lower.
It depends on the financial status of the family. Everything, it's just like with anything, the more the financial status, with the easier these things are, especially when it comes to individual therapy. I was a behavioral therapist for children with autism prior to being a dentist, and the parents with money were able to get 6 hours a day of personal one-on-one therapy for their child.
So the challenges in service availability relate quite a lot to an individual's socioeconomic status. Yes, Dr. Gottlieb?
And I would, hi, I'm Alessia Gottlieb. I would say that certainly that's the case in terms of the impact of finance on intervention for ASD, but I think that there's a tremendous amount available and becoming more and more for ASD as compared to other mental illness or mental health issues where we don't have as much opportunity through reimbursement and through state services for other children with mental health issues. So I'm also hopeful about how much we have available for children with
Are you seeing availability improve with respect to a particular type of service or intervention of these listed, or just in general?
I think with respect to, in particular, individual therapy, I think there's more barriers. and more dependent on financial issues. I think earlier intervention, it's changing, of course, changing in many of the states, but I think in terms of case management and early intervention, and some of the medical psychiatric care, we're doing a pretty good job on many levels. In California, I think the individual therapy and parent support are more difficult to come by and more dependent on financial opportunity, but getting better, getting better.
Great, thank you. From your view, what services are most needed for individuals with ASD? A, case management, B, early intervention, C, individual therapy, D, medical psychiatric care, E, parent support. I really appreciate there's those of you who obviously deliberate on these. These answers are quite thought through. So early intervention and right behind individual therapy seem to pop out the most. And we heard some descriptions about both the difficulty in access for some of these services, maybe improvements perhaps with respect to early intervention and maybe lagging but catching up, possibly with parity and legislation that has been enacted recently. We may see some improvements with respect to some of these types of care. Any other comments? Anyone from A, D, or E who might want to add a point? Well, yes.
Hi, Amy. I'm a physician and a parent of a child with ASD. I actually find missing coordination of care across various therapies, whether medical, behavioral therapy. The only place where I had actually found great coordination was when my son was in the partial hospitalization program here at UCLA. But afterwards, we ended up coordinating all of his care and have not been able to find anyone to look at the whole picture of every therapy and intervention that he's receiving and saying what's working, what does he need, what should he stop doing. So I find that a really big missing piece in at least our son's care.
Thank you. That is a very real role that in order to not miss what's going on, to really make sure everyone on the team, so to speak, is on the same page. That is work that needs to take place, and it's difficult to do without someone who really sees that as their role. Comment?
Yes, I'm Catherine Marino. I'm a BCBA, a case manager, and a sibling as well. I work with a lot of parents doing parent training as a case supervisor, and what I'm finding is the parents fill that role as the case coordinator. So the parents need so much support, not only in understanding what autism is, and I do all the training on ABA techniques to use in the home, but also I try to help them through just understanding the maze of services to the best of my ability. And it's a very, very stressful job. These parents, I tell them you need a black belt in parenting in order to parent a child with autism, because you have to be the therapist, you have to be the case coordinator, you have to be the advocate, you have to be the educational specialist, you have to be the IEP advocate, you have to know educational law, you have to know what services are out there, what charities are out there, what different types of therapies are out there, and you have to push and push and push and push. And so these parents feel so overwhelmed, sometimes they feel so alone. I see families that are desperately trying to keep their marriage together in the face of all of this on their plate. And I think parent support is really the linchpin for everything else on the list, because it's the parents who are finding the good case managers, they're finding the early intervention programs, they're finding the individual therapy, the medical and the psychiatric care, and if, if the parents are doing all that, who is supporting the parents?
Thank you. That's a great point. Okay, one more. Thanks.
My name is Melissa Quinn. I'm a child psychiatrist. And my question is, who would ideally fill that role? I've kind of felt like that coordinating care has been part of my role as a child psychiatrist. But I'm wondering what the parents are and have felt their experience has been. Who's done that besides themselves?
So let me rephrase that slightly, if you don't mind. Who's been the most effective case coordinator or coordinator of care in you all's experience?
So Corey, daughter on the spectrum, parent.
So it often, by default, the parent is in that role, and as was said so eloquently, that requires so much knowledge and effort and strength. Okay, excellent comments. Thank you. Let's talk about some other services that maybe sometimes don't get discussed quite as much, but what about other services that you see are most needed for individuals with ASD? How about things like A, academic support, D, dental care, C, occupational therapy, D, physical therapy, or E, vocational training? Oops. Okay. So vocational training certainly caught the attention of the majority of you, but also academic support, occupational therapy registered prominently. 1 out of 5 or so of you endorsing those. So, I mean, I think at times, especially for individuals who might be higher functioning, there's perhaps some, not ignoring per se, but because someone may be skilled enough to have most of their time in more of a mainstream environment, there may be less attention paid to academic support that could further assist, or likewise with other individuals as well. And OT may be difficult to access, just both because of providers, but also finding support from reimbursement sources. Yes, ma'am.
Hi, I'm Sarita Friedman. I'm a psychologist. And I think especially in the young adult population and older teens, I agree that speech and language pathology is very important because the rules of communication change. The older we get, they become more sophisticated, and most parents, when I recommend speech therapy for their teenagers or their young adults, they're like, why? You know, especially the high-functioning ones, he already talks, but it's not about talking, it's about communication. And then I find that there's a real lack of available occupational therapists for the older population of kids. You know, sometimes they don't get diagnosed till they're 15 or up, and there's a lack of occupational therapists who can help them learn how to manage their sensory symptoms in different environments.
Mm-hmm. Thank you. Yeah, just my personal view, taking the prerogative of the speaker, I certainly see among the whole range of services, just a striking deficiency in the amount of speech and language therapy for really almost all individuals, regardless of age. So let's move on here and ask a question about service integration. What, in your view, what best describes most existing service programs in the LA area? A, mostly fragmented, B, somewhat fragmented, C, somewhat integrated, D, mostly integrated. We've heard some about the challenges of pulling treatment teams together or coordination. So, well, no question, fragmentation seems more the rule rather than the exception in your view. Any specific comments relating to this? Obviously, again, from the experience of the parent or the family member, it just raises the whole burden and strain of getting what your loved one needs if you feel like there's no real easy way to find it all in one place or through one point of contact. So that is an important observation. And in terms of other unmet needs, what problems do parents often need more support or intervention for than is usually provided? A, anxiety, depression. B, difficulty with school issues for their loved one. C, managing challenging behaviors. D, physical symptoms and complaints. Or E, socialization issues. Should we have included all of the above? Sorry. So kind of a broader split here. Socialization concerns, of course, being the leader, but just managing challenging behaviors despite intervention programs and the like, and anxiety and depression being identified as well, and it's something that may be often overlooked or where it may be more difficult to identify how to find a professional to address that in addition to the other aspects of one's treatment plan or care plan. Any particular comments here? This seems to ring true. Okay, thank you. So we appreciate your feedback here, and we indeed have tallied not your individual answers, but the summation of your responses, and there are a number of us who are very interested in exactly this kind of feedback. Dr. Kuo herself studies access to care, being a pediatrician and an internist. How cool is that? And she is very keen to learn more about the challenges or barriers that individuals face as they attempt to interact with these different systems and how that whole experience can be improved or facilitated. I just wanted to spend just 2 short minutes, I promise, in just briefly describing what's going on with our own outpatient autism program. You may have been more familiar with it in the past as the evaluation clinic, which it was and still provides. But there has been a bit of a tectonic shift in our emphasis for the clinic, starting this month, in fact. And I'll describe that to you in a little more detail, but in brief, we're really completely remodeling the clinic to equally embrace providing expert assessment and diagnosis. It's quite multidisciplinary, as you can see, and we hope to expand on that in areas such as occupational therapy, social work, and other disciplines in the future. The goals can be stated as you see here, really diagnosis and treatment for individuals with ASD of all ages is the emphasis. Likewise, we see ourselves as at least at times having value in consulting with you all in a variety of ways. And I'll describe that in a few specifics, but we hope that you all will see us as folks who may help you work more closely with your own client or family member in the service of optimizing their overall treatment. The other thing, though, that this reflects is that we've been working really, really hard for at least 10 to 15 years on developing treatments. And the good news is that we have a number of successes, many of which have already been published, but we think it's time to make these available. They're not widely available, and that is indeed one of the new aspects that we're offering through the clinic. And then we see this as it evolves as a place for support and information, as was mentioned before, so often needed by parents and family members and clinicians. Here's some examples of what we'll be providing and have already started. Besides screening and comprehensive diagnosis for kids in a more typical age range of identification, we now have the ability to go down to as young as about 12 to 15 months with diagnosis. Obviously, one encounters some challenges in working with really, really young kids, but because we've been working with following infants deemed at high risk from 6 months on, this area has really evolved. So early diagnosis as young as 15, 18 months is definitely now deemed reliable. What I see as a very interesting and novel offering from the clinic is what we call our treatment matching assessment. This has been led by Amanda Gulsrud, who's here, one of the psychologists in our program. Also, Connie Kazari also has been involved in this. What this involves is bringing in individuals who feel that despite intervention being provided, they've hit a wall or progress has not been fully satisfactory. And there's just a question about what is the best approach for my child. Obviously, the answer that you may get from different service providers may depend hugely on their own background or orientation. It's not always so customized for the individual child. So what this program does over the course of anywhere between 5 to 10 visits, usually 5, is it literally tries out at least 3 different approaches, discrete trial training, or kind of good old classic ABA, pivotal response training that you'll hear more about from the Kegels later, and then Jasper, which is a new treatment that's been developed here at UCLA, which really focuses on building symbolic play skills and joint attention skills, these sort of foundations for language and emotional development. And then based on the child's response, the observed response, the feedback is really a tailored treatment plan for the child that can be carried back to the provider or to the agency. It's very exciting. I think it's can be hugely helpful. Likewise, we're also offering a brief 2-week treatment period to really kind of kickstart and identify the responsivity of the individual child to different forms of treatment. We also, again, based on actual research, Dr. Kazari and her colleagues have developed a classroom and school-based social skills intervention program that we can offer as a consultation to an individual child in school, and if the school and parent wish, the intervention itself can be implemented there. Also with individuals like Dr. Wood here, he has developed specialized forms of cognitive behavioral therapy to address social and problems of anxiety in school-age children and adolescents. And also we have expertise in the clinic now of applying, again, treatments such as PRT for brief periods for tackling very specific problem behaviors, like severe repetitive behaviors, for example, and also family support groups. And then lastly, we have a range of physicians involved in the program, and that provides an access to a number of different types of treatments, including experimental treatments. So if you're interested in more information, this is the contact information. I really appreciate all of your great comments and feedback. I think that's been hugely informative